Hello, my name is Dr. Siu Ng. I'm a gastroenterologist at the Department of Medicine and Therapeutics, the Institute of Digestive Disease at the Chinese University of Hong Kong. The editors of Gastroenterology have asked me to discuss a paper of ours that is due to be published in the March issue of Gastroenterology this year. The title of this paper is Risk of Advanced Adenomas in siblings of individuals with advanced adenomas, a cross-sectional study. There are several reasons as to why we chose to conduct the study. Although the risk of colorectal neoplasia is well established in patients with a family history of colorectal cancer, it is less well defined in families or patients with adenomas. The current guidelines recommend a screening colonoscopy in close relatives and at a younger age if the proband has an adenoma. However, when you study the literature carefully, you'll find that most of the studies that were cited for the risk of colorectal cancer in families with adenomas lack a suitable comparison group or may not have addressed the intended question. So our group set out to ask the question, what is the expected findings on colonoscopy in close relatives who have a proband with an advanced adenoma on colonoscopy? To answer this question, there are two types of study design that can be used. The first would be a cohort study, which would require a large number of subjects followed over a prolonged period of time. An alternative but more feasible study would be a cross-sectional study. So we design a prospective cross-sectional and blinded study in order to compare the frequency of colorectal adenomas in siblings of subjects who have an advanced adenoma and compare that with our control group. These are individuals who have a sibling with a normal colonoscopy. They are regarded as the unexposed group, those without the risk factor. Both of these groups were then validated using a colonoscopy during the same time period. We then match each exposed sibling with two unexposed siblings by sex and age, and all the siblings were asymptomatic. Now, in order to also limit clustering of genetic risk that may track in families, we did several steps. All siblings should represent independent families, and only one sibling were invited from each family, and they are excluded if they have a family history of colorectal cancer. So in total, we recruited 200 exposed siblings and 400 unexposed siblings. The baseline characteristics were similar between both groups. Now, the most significant finding from this study was that the exposed sibling has a substantially higher risk of advanced adenomas compared with the unexposed sibling. It was 11.5% versus 2.5%. In addition, we also found that the exposed siblings had a higher odds of having all colorectal adenomas, large adenomas, villous adenomas, high-grade dysplastic adenomas, as well as multiple adenomas. There were 2 colorectal cancers in the exposed siblings and none in the unexposed siblings. So based on these findings, I think the results have several clinical implications. So based on data using a better comparison group, as well as true verification of the advanced adenoma in the proband, we are able to show a higher association of risk of advanced adenoma in siblings who have advanced adenoma, therefore strengthening the concept of familiar risk of advanced adenomas in the proband. Secondly, the siblings of those with advanced adenoma have a greater than 6-fold increased risk compared with siblings with normal colonoscopies. So the results will indicate that initial screening with a structural examinations such as colonoscopy would be indicated in this high-risk group. And lastly, our findings also suggest that the risk of advanced neoplasia was high regardless of the age whereby the proband had their advanced adenomas diagnosed.